Hello, welcome back. Now we're going to talk about what your patient's going to look like and what we're going to do about it. So your patient is going to be dyspneic, they're going to be having chest pain, they're going to be tachycardic, diaphoretic. They may, depending on the severity of the thorax, may have their trachea deviated to one side or the other. So instead of the trachea being nice and midline, it can be off to one side or the other, being pushed by that tension inside the pleural space. They may have flail chest. The flail chest, normally whenever you breathe, your chest expands when you breathe in, contracts when you breathe out. But it all works as a unit. With flail chest, that's not what happens. One side is trying to do what it's supposed to be doing, and the other one's just kind of flopping in the breeze. It's not following, it's not working with it. It's not following along. It's not filling up and emptying the way it should. I've got some great sites for you to go to. Take a look. You've got one site where you can see a flail chest, an accessory muscle use. Very cool. Got to go look at that. Here's a site where here's a YouTube where they show an open pneumothorax, one where they show a closed pneumothorax, and they're actually putting in a chest tube, which is really how you treat these types of injuries. And listen for the cough as the lung expands when he puts that in. And then there's a demonstration of a tension pneumothorax. So these are very short, like less than 5 minutes mostly. Very short video clips. They're just really going to clarify this in your mind. You're going to look at it and you're going to get it. So just go in, look real quick at these, and it'll help you understand chest tubes a lot better. Now, this is what they're putting in. This is a chest tube drainage system. It's got 3 chambers. The first chamber is there are 3 chambers. I don't guess there's a first, second, and third, but the first one we're going to talk about is the collection chamber, because that's where all the drainage goes. If they have an empyema or if they have a hemothorax, this is where the fluid is going to go. If they have a pneumothorax, you may not see anything going in there, but it's still going to be drawing it in. It's just going to be air. This chamber is your water seal chamber, and this is what makes it be a one-way valve, so that the blood and air and fluid can come out of the lungs, but air doesn't go back into the lung, because you don't want air in that lung. You want to recreate that negative pressure area. You want to empty out that pleural space except for the pleural fluid that's supposed to be there. So you don't want anything going back in, and that's what happens with the water seal chamber. And then this is your suction chamber, and this is what really determines how much pressure, how much suction is happening. It's not what's on the wall, and I'm going to say that again in another slide, but just because we're putting at it, it's the amount of water in this chamber that decides how much suction there is. In this chamber, in the water seal chamber, you're going to have 2 cms of water. In this one, you're going to fill it all the way up to here. And I'm going to let you guys fill this whenever you come in. Somebody will get to. We can't really empty it out and fill it back up 20 times, but somebody's going to get to fill this, so you can figure out where you do that at, and everybody's going to stand around and watch. I'm not going to do it. So whoever wants to, volunteer, be brave, and see where the water goes and you pour it in places, that's going to just be a really good learning experience. There's nothing better than getting your hands on something. So you're going to get your hands on something whenever you come in. So let's talk about how we're going to assess what's going on in the chest tube. How do we know whether or not this thing is working right? For one, when you set it up, you have to turn this blue thing this way so that it sits flat. If you don't, it's just not going to sit right. It needs that extra stability. It's like a tree stand, You got to have it. But it's easier for me to talk with it up here. But anyway, just so you don't forget that. Let's talk about the water seal chamber. The water seal chamber should not have bubbling, at least not all the time. Sometimes it may bubble a little bit, and that's normal. That'll get better as the problem in the chest resolves, but it shouldn't bubble. If it bubbles really quickly, continuously, you've got a leak somewhere. It's either there's a connection that's not tight or your dressing is not tight, but you've got a leak somewhere. So you're going to have to find that and fix that, because this should not be continuously, vigorously boiling. Once in a while is okay, and it may tidal as the pressure changes in the lung, and that's okay, but it should not bubble a lot. This one, on the other hand, your suction chamber, you should see a slow, steadily bubbling, because it's constantly causing movement in there because it's doing constant sucking, okay? So you should see that. The physician sets how much suction he wants to set. It's usually about 20 centimeters of water. You add more water, you have more suction, but that's pretty typical. They don't usually change that a whole lot. All right, now that we've talked about what the chest tube is, how it works, this is actually a dual chamber. So each one of these hoses will go, each one of these tubings will go to the client. Usually one will go higher to the pneumothorax and one will go lower to the hemothorax. And I will let you discover how you fill these up with water. It'll be fun. Okay, so now that we've talked about the chest tube container, I'm going to let you have a break, let you go think about that, go read about it a little bit in your book if you haven't already, so you can get your mind straight on which chamber does what, and how you assess it and what you do about it, what you do if it's not doing what you expect it to do. And I will see you back in a little bit, and we will talk about what's going on with the patient.